when you start to learn more about the anatomy and realize that something that's considered really simple, like an episiotomy, these days, the episiotomies, I think it's overall, if a doctor's getting trained today, they're knowing that episiotomy is not like a kind of practice that's an everyday thing, but I still hear about women with episiotomies all the time.
Well, there were some hospitals where it's still the norm, and there was a period of history from the 60s,
sure. 60s,
the 70s, and into the mid 80s, where every woman got episiotomies at certain hospitals,
right.
and those women, they haven't gone anywhere. They're still experiencing their pelvic floor pain. They're out there and they need work. Episiotomy is going to propagate scars that are going to penetrate through all the layers of the pelvic floor.
And if you understand how anatomy works, you understand that that's erectile tissue. So you're not just cutting skin, you're not just cutting muscle, you're cutting erectile tissue as well. So you're basically cutting sexual anatomy. You're not just cutting muscular anatomy.
Exactly.
So of course sex might be uncomfortable. Of course penetration might be uncomfortable if the lubricating function's not working well. If it's not able to be engorged, it's going to interrupt the pleasure circuitry.
Yes. And that can then, we could go on and on about this, but what tends to happen is that people start associating a pain response to desire and arousal. Like even the fact of engorgement itself could become painful, or having the inability to lubricate and going ahead and having sex anyway, which will be painful and dry and scratchy and pinchy, will then start to propagate this ideation that, sex equals pain. And then desire just withers, because if it's painful, then where's the pleasure?
Right.
You could do it for your partner, but if you're not doing it for yourself, avoidance tends to seep in.